take care of it.
Aw.
That's a correct statement. What?
Okay.
Right.
There's several of them that we have here today that we use also in the soft A, but we kind of look at them for different reasons in here. We focus on different things. This is one that we use in the soft A. We talk about eventration, scalloping in the soft A. Remember talking about that?
Yep.
Scalloping, normal variant, eventration, normal variant. Tortuous aorta, we've talked about that. See how big the aortic knob is, but look on here how prominent the aorta is. The aorta should not be visible this far down. This is visible almost all the way to the diaphragm. And it's because the aorta is tortuous, and the reason we see this part of it is because the aorta is pushing out against the lung. Instead of being contained in the mediastinum, which is all water density, it's pushing out against the lung. Pushing against the lung means you now have that water-dense aorta pushing against air-containing lung, and it's a contrasting density around it. And so it makes it a bit more visible. What's important about this one are the nipple shadows, right here. And very faintly, it's a little hard. This one's barely visible, but it's there. In the tumor world, small nodular lung densities are extremely important. A nodular lung density. We're going to be talking about nodular densities a lot over the next several weeks as we work through tumors. It's a very common tumor presentation appearance is a nodular density. This is a nodular density. Now what does that mean to be a nodular density? It means a couple things. Circular or oval shape and pretty much well defined. How does that make it different than, say, consolidation?
Fuzzy border.
Consolidation's fuzzy, exactly. Consolidation, classically fuzzy, like this. This is fuzzy. This is fuzzy. See that? That's because that's consolidation. Good air bronchogram, by the way, also. But this is not fuzzy. That's well defined. Well defined. And tumors are very commonly well defined when they're peripheral. Peripheral. Now, that would be peripheral, wouldn't it? Because remember we talked yesterday about origin. We talked about the epithelial tumors, bronchogenic, bronchiolar, bronchial adenoma. And we said bronchogenic originate in the conduction zone airways, which is from the trachea all the way down to the terminal bronchial. But that means you go from here all the way out to here, out into the lung, in all directions. That's the conduction zone. That's where the bronchogenic cancers happen. But look, if you have one that's in a main stem bronchus, where's it going to be? Out here? No, it's going to be in here. It's going to be hilar or mediastinal if it's coming from the main stem bronchus. Those are called central tumors. Central are main stem, lobar, or segmental. And where's it put them? Right here. Basically hilar or mediastinal. If it's beyond segmental, anywhere from segmental down to the level of the terminal bronchial, they're away from the hilus, those are peripheral tumors. And some like to be central, like small cell, classically central. Some like to be peripheral, like squamous, can be peripheral. Adeno's peripheral. And it depends on how big an airway they originate from. So central versus peripheral is important. This would be a peripheral nodular density. And if this patient is over the age of 40, that is a really important red flag, because that could be a tumor. Could be. Now, the fact that we've got one on each side, pretty close to the same place, is more in favor of a chest wall density, nipple shadow, chest wall density. Because that one's going to be tough to see. Especially if the thing was sitting right over the top of the heart. If that was in the superior lingula, let's say, right over the top of the heart, that'd be a tough one to see. You know, because the heart's this big and the density's this big, it's gonna be hard to see something like that, adding it over top of the heart. It would be. So that's the importance of that one. That's a peripheral nodule. Tumors, anybody look at the fun fact sheet?
I have it in my bag. Let me get it.
Okay. What percent of tumors are right-sided versus left-sided? 60% are right-sided, and 40% are left-sided.
Space.
Why is that? I have no idea. Statistically, right lung is more common than the left lung by 50%, 60 versus 40. Central versus peripheral, which is not on the sheet. Central tumors outnumber peripheral tumors by about the same amount, about 60-40. Now, peripheral tumors, which this would be a peripheral tumor, wouldn't it? Let's say it's a tumor. That would be a peripheral tumor, and it's in the left lung. So it's on the less common place to be. Tumors are also then divided according to whether they're upper, middle, or lower. Or on the left side, 1, 3, 2, lingula, or lower lobe. So we use the left side similar to the right side. And there are percentages for each lobe, which is on the sheet. What does it say? Upper lobes.
Upper lobes are 30%.
No.
Right? No, 60.
60, uppers.
Oh, I didn't see what the come was.
Yeah.
And then the lower lung is 30.
30. And middle?
10 is middle.
Middle and lingula are 10. That's for peripheral tumors. So, using the whole lung, what percent of peripheral tumors are in the right upper lobe?
60.
Oh, good. 60 is a big number.
Wait, we said
You
right
said
upper.
upper?
60%
for right
are on
and
the right
60
side.
for upper.
60% are right side,
And
60% are
and
upper.
60% are right upper lobe. So what's the percent of all tumors that are in the right upper lobe that are peripheral?
36.
36%.
Oh, 36. Oh, yeah.
It's 36%. Everybody understand? That is about 5th grade math.
Good.
Okay? So where is the least common location for a peripheral lung tumor? And what's the percentage?
Left middle,
Lingula, what percent?
4%.
4%.
Oh, yeah, because it's 40%.
So it's 10% of 40%. No, left side lingula is 40%. So it's 10% of 40%. Everybody understand how
Yeah,
that
now
works?
I do.
Because we're gonna do it in class again, and there's gonna be a lot of deer in the headlights.
So go
Are we going to do it on the midterm?
Say it one more time, Brother Rob.
Okay. So you take whatever lobe it is. First, is it right or left? That gives you your 60-40. And then you take the percentage of that. So right upper lobe was, right side is 60, and it's 36%. So it's or it's 60% of 60. So it's 36%. 36% of all peripheral tumors, right or left, 36% of them are going to be in the right upper lobe. And that's the most common location for a peripheral lung tumor, is the right upper lobe. I don't know why. Statistically, that's where those numbers come from. They come from looking at thousands of chest x-rays and where are the tumors located, and that's how the breakdown works. That's how the breakdown works. So lingula is the least common at about 4%, and the right upper lobe is the most common at about 36%. Okay. Okay, so that's the importance of the solitary pulmonary nodule, and we're going to look at that in a lot of detail. A lot of detail. Look at this one. Increased density here, increased density mid and lower here. and a little bit of fuzzy density here. The best explanation for that is consolidation, isn't it? Even though it's bilateral still kind of localized. And remember, when we have bilateral localized, how do we do it?
Cat P.
How do we deal with it? Well, it's still in the cat P, but it's not unilateral localized, it's bilateral localized. So how did we cover one up? Because if you just cover one up, then you got unilateral localized and it still works. And it still works. And this is a bit of an air bronchogram, isn't it? Okay. In the tumor world, tumors are not very common consolidation. It's not common to have consolidation. And the reason is because they're a solid mass typically, and so they have a greater tendency to be well defined. But the bronchiolar, that second one on the list, the one that's distal to the terminal bronchiole, that's in the respiratory zone, alveolar cell carcinoma, comes from the cells lining the alveoli. And those cells just slough off from the alveolar membrane and they fill up the airspace. Blood, pus, water, protein, cells. That tumor looks like pneumonia. That tumor is an airspace consolidation pattern. You have to remember that tumors can look like pneumonias. Pneumonias can look like tumors. Yeah, Dan is right. That's right. That's the scary part about tumors. That's why when we have a patient that's over the age of 40 that has a localized area of water density, T of cat P's got to be high on the list. And if they're a smoker over the age of 40, bingo, it is a tumor until somebody says, no, it's not. Whether it's got a well-defined margin or a fuzzy margin. It is a tumor until somebody says no, and it's going to be the pathologist that's going to say, no, it's this. Because radiographically, you can't tell. It doesn't matter who you are, you can't tell. So that's how we deal with it. This is more likely to be a pneumonia, just because of the fact that it is bilateral, and sometimes pneumonias can be in more than one lobe. They can be. So remember, consolidation can also be a tumor. All right, let's look at this one.